So this is Dr. Hood's helping others overcome determinants LLC inclusion exclusion criteria training. Thank you for coming.
Thank you for having me.
So this page right here is just some common acronyms that's used in clinical training. With your background, I'm sure you're familiar with all of most, if not all, but just wanted to reiterate that we're going to be just talking about the inclusion exclusion criteria, which feeds into the medical history of a patient and the concomitant medication of a patient. Okay, so on the agenda, we was going to have the introduction of the host, the introduction of the group, going to talk about pre-screening and recruitment. We're going to do a discussion question. Then we're going to go into the concept of the inclusion criteria, the concept of the exclusion criteria, how to document both, deviations, the responsibility of the site and the CRA as it relates to the inclusion. We're going to take a break and we can kind of determine if that's necessary based on how this flows. And then we're going to go into the scenarios and then we're going to do our takeaways. Okay. Okay, so just a little introduction about myself. I hold 3 degrees, one in biology, a master's in clinical research administration, and my doctorate in public health. I'm also a certified medical assistant. I started my career off as a patient care tech in a local hospital, did approximately 6 years, 3 months, and then I went into the clinic and did lead patient care tech for ENT. And then transition out of patient care for 1 year to be a patient encounter specialist, same department. Then I did almost 10 years as a study coordinator, endocrinology and diabetes clinical research unit. I've been a CRA for nearly 4 years. August the 1st will be 4 years. I started off 10 months with one organization, and then I've been with the current one since August of 2022. And then I started my small business March of 2025. Want to just educate people more on clinical research, give them proper training. Not all onboarding processes are the same, and clinical research is forever changing. So I wanted to provide some type of a go-to place that people can learn some of the changes and the basics of clinical research. Um, also want to prepare them for those positions as well. So offer um, interviewing practice and resume revamp. So that's the gist of Dr. Kendra Davison. And one of my slides. Okay. I must have did fast because I don't know how went past that slide so quickly. So you kind of already introduced yourself over before we start recording. But there's one question on here you didn't go over. So what is just the icebreaker? What is your favorite instrument to play or listen to?
I love guitar.
I see, and I'm a tie between the guitar and drum. I couldn't really, I couldn't really pick, but I think I'm
Mm,
gonna go with guitar too because although I like the pounding and the beat of a drum, the guitar you can still kind of hear the words. So
yes.
I think I'm gonna go with guitar. But yeah, those were my two.
Mm,
Okay, so we're gonna get into pre-screening. So pre-screening is a very important aspect of the inclusion exclusion criteria. Usually that list is pretty long and it can be or it can be short, but if you doing a drug trial, it can have several different criteria, both on the inclusion and the exclusion side. But you want to pick out maybe about 5 that off the bat you can just have a conversation with a patient and you can discuss those two different categories, whether it's the inclusion or you want to try to eliminate, or the exclusion you want to try to eliminate, and you want to assess the likelihood of how likely that person will pass the screening process. So that's basically what pre-screening is. If you can't speak to the person, you can also pre-screen by looking over their medical records. But we want to make sure that we have the legal right to, because we don't want to violate um, any HIPAA laws by reviewing somebody's medical records that we don't have access to. Now, by me working in a teaching hospital, when the patients, it's not every visit, but every so many visits, they'll hand them like the Bill of Rights, and they'll let them know that your medical records might be reviewed for research purposes. So it was kind of an expectation working at that teaching hospital. There was a possibility that you will be contacted, but because I worked in endocrinology, I only had the privilege of looking at the physicians within endocrinology patient database. I couldn't go into another group, internal medicine or cardiology, without the written permission from the provider. So inclusion, pre-screening the inclusion and exclusion criteria are the backbone of pre-screening and recruitment process. Pre-screening serve as a brief version of the inclusion and exclusion criteria to assess a person's likelihood of being eligible for a trial. The recruiter can gather pre-screening information by obtaining ethical access to a person's medical records for review before speaking to them. Pre-screening can also be conducted by calling or speaking to a potential participant and completing a brief survey. Please keep track of pre-screening efforts as the agreement between the PI and the signed contract may require it. So some trials have what's called the pre-screening log, and then you put just brief information, maybe the patient's date of birth, the indication that you're looking for, whether they did or did not have it, if they were on the proper medications that were required for the trial. That's typically what those pre-screening charts will have. And then you want to keep records of it. And the reason why it's a good thing to keep records of it, because if every site is having the same recruitment barriers, it's possible that the sponsor can go back to the drawing board and see if that inclusion or exclusion criteria can be tweaked. Now, they don't need to do it if it's not an ethical reason to change it, but sometimes maybe they can reassess whether a lab value posed a real safety issue, or if we change the age, maybe we can get more people. Or if they said you have to have a certain condition for 6 months, what if we said, most of our patients have had it for 9 months or a year? Will it affect the integrity of the trial to change that inclusion exclusion criteria if based on the barriers we're seeing during the pre-screening process? So that's why it's so important to document the pre-screening efforts. Also, if you having a hard time enrolling and the CRA wants to come and do what's called a booster visit just to discuss, the recruitment issues, you have your proof. So you're not just saying, hey, we just can't enroll anybody, deal with it. You can show them, hey, I looked at 100 patients, I looked at 200 patients, and just based on this database, they just do not meet your inclusion exclusion criteria. So that's a good reason why it's important to document. Any questions about the pre-screening process?
No, thank you.
Okay. Okay, so recruitment. During the enrollment process of a trial, recruitment can be aided by advertisements such as radio ads, social media, brochures, and all of these documents have to be approved by the RB. So anything that the patient sees has to be approved by the RB. So if we're going to post that poster like in the waiting room, or we're going to put flyers or brochures in the exam room, it has to be approved by the RB. A physician to physician letter is when it's like a template where it's like a brief summary of the study, and of course you add the physician you're addressing and their address. You're basically asking if they feel comfortable referring patients to you, or referring patients to the principal investigator, I should say. So that's what a physician to physician letter is. Enrollment and recruitment can be competitive or non-competitive. So competitive is when there's no limit of how many patients a site can enroll. Um, Sometimes I don't always agree with this process because how fast one site opens is not the same as another site. So some sites are not academic places, so they can get their IRB approval and their contracts pretty fast. And as soon as enrollment open, they can hit the ground running. Whereas academic places or small clinical research places, it might take them a little longer. Or they might get identified by the sponsor, maybe not at the beginning of the trial, but midway, just so they can meet their recruitment goals. And by the time they are able to enroll, they can only get maybe 4 or 5 people, whereas you got other people, other sites have done in the hundreds just based on when they had the opportunity to enroll. So I guess it just depends on how fast the treatment has to be available to the public. But sometimes that competitive enrollment can be a little fishy if everybody's not, well, I won't say fishy, but it can be a it can seem unfair if everybody's not starting at the same time. Now, just because a site or the trial has been deemed competitive enrollment, it does not mean that there's not a cap per day.
Mhm.
So randomization is based on the availability of the drug. So if that initial and a lot of times that drug is automatically redispensed based on how many people that you randomize. But if you're randomizing a lot, you do need to make sure that the sites do need to make sure that they wait on that next shipment and drug before they screen people and they don't have the drug on site and then they go outside of that screening window. So we want to make sure that they have access to the drug and keep that in mind before they just decide to just start screening a lot of individuals. And of course, non-competitive means there is a limit. Um, and the sponsor will make that known and the sites need to abide by it. And sometimes they will actually even cut off the IoT randomization buddy just to get enrollment under wraps and then they'll open it back up. Okay, and then if you have an referral company, so there are some referral companies out there that sponsors will have a contract with that will work with sites and refer individuals that have a likelihood of um, being eligible for the trial. So not only can the site do a pre-screening process, but they can hire one of these companies to do it as well. And we want to keep in mind when we receive a referral, we want to make sure we contact that patient within that window. So if they send you a patient or send the site a patient and they indicate that that person needs to be contacted within 72 hours, we want to show good efforts that we're doing that because if we increase the window between the time the pre-screening company contacted them and we contacted them, then the patient may lose interest. So we want to make sure that we follow up during that time period so we can increase the patient's interest in participating in that clinical trial. So any questions about recruitment?
Yes. I
Okay.
was just thinking about the competitive enrollment,
Mhm.
and do you, do you know like how the sponsor will mitigate the risk of having imbalance when it comes to the demographic of the study?
So usually in the training overview or the SIV process, they will indicate how many in each ethnic group that they want to be in the trial. So if they notice that this one site might have a higher population of Caucasian and they're trying to get other races or ethnicities in, they might halt that particular site because they have the power to do that. They can halt a site's enrollment to allow other people to enroll to maintain that balance or that diversity in their clinical trial. So that's usually how they do it. They can halt one
Mhm.
site based on looking at the demographics that they're putting in the EDC system, and they also send out memos. So hey, we've enrolled 100 patients. 65 of them are this, 10 of them are this, 5 of them are this. And so we want to make so they're going to encourage the site to these are the demographics that we want you to look for because we want to make sure we meet the FDA's requirement of diversity before we present our interim analysis or our database analysis to them. So that's usually how they do it.
Okay. And then my second question will be about the referral company. From my experience, what I notice is sometimes, for example, if I have like type 2 diabetes trial, they send us referrals through, like the portal, but looking just even before contacting the patient, looking at the pre-screening form that they use, for example, I would find like a subject, they don't even have the indication.
Yep.
Yes.
We experienced that and we used to complain like they'll send
Mhm.
us 15 people, but only 8 really qualified. And by the time
Mhm.
we contacted those 8, 2 didn't even know what we was talking about. And the other ones didn't want to participate. So I understand that. But that goes to show you based on what 5 or 6 questions they pick for pre-screening versus what 5 or 6 questions you might pick to really get an elimination of who shouldn't qualify. And I know I can give an example. We were doing a cardiac outcome study, but the
Okay.
patient had to have diabetes.
Mhm.
But they were just looking for whether or not they had hypertension, they recently had a heart attack, and whether or not they was on the right statin drug. But they didn't even always make sure that the person had diabetes. It was a
Mhm.
diabetes cardiac outcome study. So I know exactly what you're talking about. And with that, um, the CRA is the site's support system. So I would suggest anybody that's listening, if you have that situation, communicate that with your CRA. The CRA should communicate that with the person above them to see if a conversation could be happening between either the sponsor or the CRO company and the vendor to make that known so they can be more aware of what is happening because it does waste a lot of time. You take the
Mhm.
time to run down the list. You know in your head these people at least meet these minimum qualifications, and then you talk to them and they don't always. So
Mhm.
great for pointing that out.
Thank you.
Okay, so this is the little discussion point. Why is it essential to pre-screen subjects before bringing them to the site?
I think with the pre-screening, it helps a lot, especially with high enrolling studies. So if I have, for example, type 2 diabetes study, but with very specific criteria, it will be kind of pointless to bring 50 subjects. Some of them are pre-diabetic. They don't even, which 30 of them pre-diabetic, so they're not going to even qualify.
Mhm.
So,
So So great. So basically, it's to help minimize the chances of bringing in people who don't even qualify. Now you have to be kept. Sometimes sites get paid based on even get paid for their screen failures. Now,
mm,
usually it might be a ratio for every randomized person will pay you for 2 screen failures. Usually
mhm,
the contract is written something like that. But as a CRA, if you come and you're reviewing inclusion and exclusion criteria, and it's just like obvious that that person didn't qualify, but they did all the assessments anyway, that's the
mhm,
time to talk to the principal investigator because they're really wasting resources. They're wasting time for the couriers to come pick up the shipment of the labs. They wasting time for the labs to be processed. All when they just could just review the medical records of the concomitant meds and know that the patient didn't qualify. And that's basically what the scenario later on is going to be about. And it's probably just, going to be just as fun just between us doing it. Okay.
mhm,
So the concept of inclusion criteria. So the inclusion criteria are a list of conditions that a participant must have to participate. So it's no ifs, ands, or buts. Whatever listed on that inclusion criteria, the patient must have. It could be a therapeutic indication, the specific demographics, a stable dose of a particular drug. So sometimes the patient can be on the drug, but not on a drug long enough. Like if they said stable dose is defined as at least 3 months, or defined as 30 days, or defined as 1 year, whatever's defined in the inclusion criteria, they must have. So they just cannot be on the medication, but they have to be on the stable dose of the medication. So they have to be willing to complete procedures. Oftentimes that's like a diary or extra phone calls. Some can even be at home visits. They got to be willing to do that. Of course, they have to be willing to sign the informed consent form. That's although it's usually the one of the last things on the inclusion criteria, that I've noticed from my experience is still the most important. They have to sign an informed consent. Um, okay, then we go to the next. Okay, and same with the exclusion criteria. They have to have lists that participants must not have to be eligible to participate. This serves researchers by recruiting a homogeneous sample that aligns with the study's objective. So this is the reason why you have the inclusion exclusion. You want to make sure the patients are as close as possible so you can run a true analysis. You can't test diabetes on a person that doesn't have it, and add their lab values and their vital signs and that sort of thing if they don't even have the indication. So that's the whole point of the inclusion exclusion criteria, to make the sample size homogeneous as much as possible. And of course, it's the opposite of the inclusion: unstable dose, unwilling to do the procedures, unwilling to sign an informed consent. Okay, documentation. So I was probably a study coordinator about, I would say, 2 years, because when I first started, I didn't do pharmaceutical trials. I was basically the primary recruiter, and I would just help the nurse with visits. And I did two pilot studies that one of the investigators had done themselves. So that's kind of how I got my start. And so this first one is real important to me, because it was about 2 years before somebody told me this. During the construction of the source documentation, an inclusion exclusion checklist should be created to mirror the list provided in the protocol. So basically, we just had a little box and said subject met inclusions, subject did not meet inclusions, PI reviewed the list, and he or she would sign. Then one of them monitors came in and say, no, you need to create a checklist, and then your responses need to be yes, no, or NA. I started in 2011. So it was about 2013 before somebody had mentioned that I needed to make a checklist. So that is so important, because it really ensures that the PI didn't skip over anything, because like I said, those lists are typically long, and by you having a response to each one, it verifies that the PI did not overlook anything. There should be evidence that the PI has reviewed before the participant is randomized. So it's important that PI signs the inclusion exclusion checklist date is before the subject is randomized. Because if the subject is randomized and then the PI does the inclusion exclusion verification, it might be a safety issue. It might be a lab value that it would have excluded the patient. Although they depend a lot on the study coordinators to provide this information to them, it's ultimately the PI's responsibility. They should be clear documentation. So again, that yes, no, or not applicable response. If the protocol permits retesting, is completed for inclusion, both results should be assessed and maintained in the patient's chart. So we never get rid of anything. So if it was a lab value, that the protocol allows to be retested during a certain period of time, we still want to keep that original documentation or that the original lab report and place it in the subject's chart. It is imperative that the inclusion exclusion of a medical condition is required for the study. The site staff and clinical research associates should know when patient-reported outcomes are acceptable or prohibited. So basically, it's important to know whether you can accept word of mouth, like, yes, I have diabetes, yes, I've had a stroke, yes, whatever, or if they want physical medical records. And it's important that not only the site knows that, but the CRA knows that. So even though if they create that list with their written medical history and they create that list of that written concomitant meds, we need to know if the sponsor wants to see actual clinical notes associated with that screening visit. And for concomitant medications should be assessed against the study's protocol's prohibited medication list where applicable. So not all trials have a prohibited medication list, but when they do, we just want to make sure that that subject's reported concomitant meds are not a prohibited medication. Okay, so knowledge check. Which documents help the principal investigator and CRA verify the individual's eligibility to support the inclusion exclusion criteria? So
I'm sorry, that would be the medical records
Yep,
from the subject PCP
yep,
and also sometimes the screening visit source documents.
yep. So that is exactly right. So those medical records help us verify what's in that source. We can also get for their medication list, if they, for whatever reason, medical records are not required, but you want to have some concrete evidence that they're on the right meds, right dose, they can get that list from their pharmacist as well, and we can add that into the chart. A lot of times when they're on a vaccine study, and we have to make sure they haven't had the vaccine a number of times or within a certain window. So, but their full medical records are not required. Then we can get their vaccine records to make sure that they are eligible for the clinical trial. So, good job.
Thank you.
So, responsibilities of the site's PI and CRO, sponsors CRA documentation of the inclusion exclusion. So we're just gonna bring this down a little bit. So okay. So the site staff and the PI. The study coordinator must ensure that medical records are obtained. So we pointed that out. It is so important. It's also not only to adhere to the protocol, but again, for a patient safety reason. We want to make sure we're not placing a patient in a study when they have a medical condition that this medication that they might be investigated can cause them harm. We want to document accurate medical history. So we want to make sure we got as much information. Sometimes patients don't always remember the month that they were diagnosed with something or the date, but at least get that year that they were diagnosed. And we just have to put unknown for the other two. We want to make sure we get an accurate list of their medication. We want to collect screening assessments within the Pacific window. So a lot of times that screening window is between 28 and 30 days. So we want to make sure that we collect this information within that window, because the reason that window exists is because a lot of times a patient can't have a certain condition or maybe be on a certain med, or they feel like the values of the labs have lapsed too long to be randomized for safety reasons in the study. So it is important to adhere to that window. Be mindful of diagnostic testing scheduling within a screening visit. So if we know that we see a patient and we send out the labs and it takes 3 days to get the lab results back, and but we don't want to send them for their echo or their DEXA scan or their MRI until we at least know that they meet the criteria up until that point. We want to make sure that we schedule those testings still within the screening visit so we can get the report back in time so they can be randomized on time. Do not complete unnecessary screening processes. So that's basically if you know their age don't qualify, don't even waste time collecting medical history, inclusion, exclusion criteria. If there's a BMI requirement for a study, the first thing you got was the height and weight, and you see that the BMI is too high or too low, don't do the rest of the work. It's unnecessary. You'll just indicate what exclusion criteria or inclusion criteria that they did not meet, and that's the end of it. We don't want to do unnecessary work. Make screening labs available for assessment and review. So we want to make sure we know how the site is going to receive those lab reports. Are we going to be emailed? Are they going to fax? Are they going to do both? We want to make sure we know how we're going to receive them so we can get them to the PI or medically qualified person in a timely manner. And again, the PI should review all inclusion, exclusion criteria, and this will include the patient's medical history. So the PI also needs to sign that they reviewed the medical history and maybe initial somewhere that they reviewed the comments, because it, especially if those conditions are listed on the inclusion, exclusion criteria. And basically, the CRA job is to verify all of that. So we verify the medical records are there. All the pages are there. Nothing has been redacted. The medical records in that patient's chart belong to that patient. We want to verify the medical history by looking at the medical records. Same with the concomitant meds. We want to make sure the screening assessments were conducted in accordance to the protocol. We want to review the diagnostic testing scheduling, make sure those reports were available before the patient was randomized. We want to verify whether unnecessary assessments were complete. Again, if we see a pattern of the site screening just to be screening when it is obvious that that patient did not qualify, the CRA is going to have either a hard discussion with the PI, or they're going to escalate it to the person above them so they can have that hard discussion with the PI. Try to find out, is there a training issue, or if they're just deliberately just screening these people just to get paid. Excuse me. So we need to find that out. And we want to, again, review and verify based on dates that PI signed that inclusion exclusion criteria before randomization. Okay, knowledge check. It is permitted for a PI to ignore an inclusion exclusion criterion for the safety of a specific participant and to randomize the person in the study as every participant is unique. So is that allowed?
Not allowed. That's a IP reportable protocol deviation.
Correctamundo. So it is not allowed. Now, they can make the decision that it's unsafe for the patient to be randomized and just decide, I'm not going to put this place, based on, even though it might not be necessarily a exclusion criteria for the protocol, but based on just their other medical issues or transportation issues, they can say, this person won't be able to do this trial. So a patient can meet the inclusion exclusion criteria, but the PI, for whatever reason, decides not to put them in for patient safety reasons. So I do want to point that out. It's still up to the PI's discretion if they want to randomize that patient. A good example, if a patient had um, a head injury, traumatic brain injury, maybe from a car accident years ago. Okay, car accident, brain injury is not on the inclusion criteria, but the PI just, using their medical judgment, the likelihood that this patient being cognitive enough to keep their visits, take the medicine as they should, is probably not going to happen. So they need to make that judgment. Me personally, I actually screened somebody. I want to say it was a cardiac outcome study as well because she had had a stroke. And we needed people who have had a stroke or heart attack within the last 5 years. But she was paralyzed on one side and it had dramatically damaged her cognitive ability. So, and I noticed that when I was trying to read her the informed consent and go over that process, and she was just repeating the same thing over and over again, and she was actually dropped off. I was quite surprised that her caregiver did not stay with her, but I just thanked her for her time. I still gave her the $25 gift card for coming, but I just could not let her sign that consent form based on how she was responding to me.
You made the right decision.
Okay, so you kind of already hit on it. So those inclusion, exclusion, deviations. When a participant does not meet the criteria for inclusion, exclusion,
Oh, I'm
it
sorry.
is.
I'm seeing part of the screen.
Hold on, let me see if I could. It's that header. There you go. Can you see it now?
No.
Hmm.
Okay, I can see it now.
Okay.
Thank you.
Okay. Oh, you were saying part of this part.
Yes.
Okay, yeah. I had moved it out the way just because of the words.
Uh,
Okay, so the inclusion, exclusion, deviations, and like I said, you already mentioned it, is when a participant does not meet the criteria, but the PI has failed to screen fail them and they have randomized them. Um, When a participant does not meet the criteria for inclusion exclusion, it is essential for the PI designee to screen fail that person and know which criterion they have failed. So that's a good thing to it's not always required, but it's just good clinical practice. If you screen fail the patient, we need to document again, and it'll be documented if you completed that checklist. We need to indicate which one that they did not meet. Sometimes it's required to put it in the EDC system. So if we screen fail somebody, we need to say, okay, inclusion 4 was not met. This person was not the right age. Inclusion 10 was not met. This person did not have the right medication. Exclusion 5, this patient BMI was too high. So whichever one that caused them to screen fail, we need to make sure that it's documented. Um, Suppose a participant does not meet the inclusion exclusion criteria, but has inadvertently been randomized. In this case, I got ahead of myself. This is the deviation. And the PI or designee should report to the clinical research organization through the CRA, who will then report to the sponsor. Typically, this is caught by the data management team if it's not caught by the CRA, or at least that's the goal. When they're doing that, what that's called that central monitoring, and they're looking at medication lists and they're looking at medical history, and they're looking at what we put in the system, and they also can see the lab results. They're kind of the backup to catch if the CRA didn't catch, if the PI didn't catch. It's supposed to be already predefined parameters put in place to alert if a patient didn't meet an inclusion exclusion criteria. Now, that doesn't always, it just depends on how they built the EDC, but that is the goal. And so what happens also when this happens, usually, unless it's just an extreme safety issue, the patient is allowed to continue, but the site will take that deviation. But that's up to the sponsor. So the sponsor will decide whether it is safe for that, but depending on which inclusion exclusion criteria that they inadvertently overlooked, they would decide whether or not it's okay for that patient to continue or if they need to be immediately withdrawn. And they probably also will make the decision if the treatment of that patient needs to be unblinded as well. So that's why it's very important to follow the inclusion exclusion criteria, because you don't want that happening. You don't want to have to get the medical monitor involved to see if the patient needs to be unblinded, to see if the patient can continue, or if some adverse events happen due to being incorrectly randomized, because that's a possibility as well. If we have a drug that has a high probability of contributing to liver damage or kidney damage, and these patients were already on dialysis, this patient was already in kidney failure, or this patient already had cirrhosis of the liver, and they were randomized, that can be a huge, huge, huge problem. So the faster we catch it is the better. Mm-hmm. And we hope that the patient did not experience any adverse events from this mistake. Again, if the CRA sees that this is a site that's a repeat offender, this PI is constantly overlooking the protocol, overlooking the inclusion exclusion criteria, and just putting patients in because either he just wants to get paid or he just has disregard for the protocol. Either way, he or she needs to be reported to the person that above the CRA, and they need to decide if they need to reach directly out to that principal investigator, or if the sponsor needs to reach directly out to that principal investigator. Because it might be determined that moving forward, that site will not, or that PI will not be selected for future studies. So that's why this concept is so important. And the PI must determine whether this also meets the criterion for reporting to the IRB. So more than likely, this does fall under every IRB's properly reportable finding, but it's always just important to familiarize yourself with the IRB that your site is using, and move forward, based on that information. Anything you want to add or any questions?
Yes, I have a question.
Okay.
So in a situation like that, let's say a subject was inadvertently randomized into the study where they don't qualify, and then let's say they found out like months later after the subject has been in the study for a period of time and been on a treatment. When it comes to data management and the statistical analysis, would they always remove the data of this subject from the assigned arm?
So they will only remove it if the sponsor has decided to, and typically the sponsor will not. They will not remove it unless they also decide to remove the patient from the study. So if they've made the decision to keep that patient in despite that situation, then 9 times out of 10 they're going to keep that data. But if they don't want to keep the information, they don't want it included in their analysis, 9 times out of 10 they're going to get rid of that patient in the study. So it's the sponsor's call. Typically, again, the PI can make that call if there's a safety issue, but that leads to the severity of what the IRB is going to say once you report it. Like if we caught it, a lot of times when a CRA comes on a site, especially with the first few patients, it's within like a week. They'll say, we want you to do your first visit within 7 days, your first visit within 10 days. And hopefully they catch it early. But when it's not caught early, it's a lot of blame in that situation. Because the first thing they're gonna say is why the PI overlooked it. So we need to do an explanation, documentation of why the PI overlooked. We need to investigate what was their inclusion exclusion list, was there actual medical records, or did the patient report? was the PI the actual person that evaluated the labs or evaluated the medical records, or did he have a sub-I doing it? So we need to figure out in that chain of that happening, where's the possibility that the right thing broke off? Then it's a CRA, it might be a CRA issue. Now, with this risk-based monitoring, some patients may not be on your list to review. So it's a possibility the reason why that patient was overlooked because that was not one of the patients that they said for you to review. You get a list of data points or you get a list of patients, however your risk-based management model is set up, and you might not even have looked at that patient. Me, I try to look at all of my patients regardless. But you have some sites that have high enrolling. You got 2 and 3 100 patients, and if they say look at 20% and they give you a list of 20%, that person is going to look at that 20%. So it depends on the model. Then you got to figure out why data management didn't catch it. Again, if were the patients' visits charted appropriately. We have 3 most studies are designed where they want the cite the chart in the EDC system within 3 days of that visit. Is this one of those sites that don't chart on time? Because unfortunately, you have some sites, you know, the reason might be different for each one, but you have some sites that just don't chart on time. You can be on visit 3 and they haven't even put the randomization visit in yet into the EDC system. So you have to investigate. As the CRA, we have to investigate why this happened. Then we have to have that conversation with that principal investigator. If we find out, you know, it was him or it was her that say that they reviewed the inclusion exclusion criteria. It was him or her that reviewed the medical records. And then it's going to probably prompt you to review everybody else, double check everybody else. So that one patient's mistake might prompt you to just say, let me just go back and look at everybody else just to make sure. But those are the three entities that's supposed to catch it. First the site, then the CRA, then data management. And if all 3 of them fail, we need to find out why. And it's probably going to be a quality issue that needs to be created, and a CAPA, a corrective and preventative measures to be put in place to prevent this from happening again.
Thank you. I have a second question.
Go ahead.
So, in a scenario where the subject came in for a screening visit, they are in screening period, and during the on-site screening visit, one of the assessments that they have completed, the results came in as inclusive or in a way where the PI couldn't determine if the subject would be a good fit for the study. So the PI would wanted the subject to go for further assessments to a specialist. Is there, I'm trying to find the best practice when it comes to this situation. Would it be the PI at the time did not want the subject to even continue the screening visit assessments until we determined if the subject would qualify.
Was it like a heart condition?
Yes.
Mm-hmm.
So per the sponsor, they wanted to continue the screening visit assessments and then for the subject to go after that and be evaluated. And that when we decide to screen fail them or not, or move forward. So my question is, would the sponsor decision override the PI decision in a situation like this?
I don't think so, because usually an inclusion exclusion criteria always have that one that says in the investigation terms discretion or judgment that this patient does not have a medical condition that would prevent them from participating. So if it has that in that criterion, then the PI is within their right to say, I don't want to continue the inclusion and exclusion process. Now, did the patient already sign consent?
Yes.
Okay. So if they already signed consent, I don't see the harm if it's not an emergency for you all to complete the assessments. But the sponsors rely on the medical expertise of the PI. So if it was me, I'm gonna be in favor. I might not need to say this on out loud, but I'm gonna be in favor of the PI because he or she is seeing the patient. They're seeing their responses to maybe the questions you all are asking, or maybe labored breathing. They see swollen fluid being backed up. And they do a physical exam a lot of times associated with the screening visit. So upon doing that physical exam, they can assess that this patient is not a good candidate. The sponsor needs to accept that person's medical expertise. That is why you made a contract with them, because you're relying on their medical expertise to make those judgment calls. Now, if the screen, because like you said, either way you was gonna have to screen fill them. If a lab came back that that was exclusionary, it was gonna be screen fill. So why put the patient during that process if the PI is gonna screen fill them anyway, because they don't feel like the person is healthy enough to do the trial. So I guess it depends on who's speaking, but I'm going with the PI. I'm going with
Thank
the
you.
I'm going with the PI.
Thank you.
Okay. So what was it's two, and what did you notice that this person met?
Okay.
Patient one screened on August the 1st, 2012. Date of birth was 1/10/63.
Okay. I think it was the date of birth. It was
Okay.
1963, and
Okay,
he was
so
screened at 2012, right?
yeah, so all of these are 2012, and the age has to be between 35 and 70. In 2012, if they're born in 1963, that person is 49.
Okay, so they are included.
So the age was not one. Yeah, I did that purposely, changing the year to see if uh,
Mm-hmm.
my students would catch that.
That is true. I think was subject 3 was the one who was born 1941, therefore did not qualify.
That is correct.
But subject 1, I'm still trying to see. I'm on my phone.
I give you I give you a hint. Look at the exclusions 12 through 16.
Oh, I'm sorry. Can I see the subject? Because I only see the inclusion exclusion,
Yeah.
but I don't see the subject. Yes. Thank you. Okay. It's the okay. Oh, ALT.
Yep. So
Mm-hmm.
the ALT is 76. It's too high.
And then the EGFR is more than 45.
It's at 45. So it can't be less than 45.
Uh-huh. Okay. Yes.
But there's one more thing.
Mm-hmm. An ejection fraction at 45. And it cannot be less than, I think,
Now,
25.
now the other thing is not under labs, it's somewhere else.
Okay, give me 1 second.
So only the ALT was a lab issue.
Anything else? Is it the medical history?
Okay, go back to see which one.
Mm, labs.
Go back to 18 on the exclusion and see if you can think about um
Mm. Okay. Oh,
oh no, 8. Right. Yeah, 8. Exclusion 8.
okay.
You want to go back to the person.
Im- Immunosuppressant medicine.
Mm-hmm. And which one is it?
Um, hold on. I know the metformin and the Humira.
It's the Humira. So
Okay.
that's the two things, the reason why he didn't qualify. And not only is he taking Humira, his medical history does not say why. So as a just for accurate documentation, a CRA coming in and doing a reconciliation of comments to medical history, they will probably ask the site to include in the medical history why he takes the Humira. Now, oftentimes when a patient is screen failed, you do not add the medical history or the concomitant meds into the EDC. It just depends on how the study is designed. But for that source documentation purposes,
Mm-hmm.
and the CRA might ask them to find out why the person took that medication, although it's already exclusion. It, you know. Now let's just say Humira wasn't an exclusion. It is imperative that the site do find out why that person takes that medication and add it to the medical history. Okay. What about for patient 3?
3 was the age.
Okay, and it was 2 more.
Okay, give me 1 second. Let me look over it. ALT below 30. And then BMI above 45.
Okay, now let me go back. Now for a male, you said
Oh,
the ALT.
mm-hmm.
Okay, it has to be between 6 and 8, so that's not one.
Okay, that is
But
true.
what was the second one you said?
Oh, the BMI was above
Yep.
45.
Yep. So the BMI is too high by 2, and there's one more.
Okay, can we please go back to the
Oh,
picture?
sure, sure, yeah.
Okay.
I'm just so afraid to give the stuff to people ahead of time because,
Mm,
like, I thought it was going to be 10 people and they didn't show. So I I'm still trying to determine when is the good time to give them the information and see if they can print it off. But I don't want to provide it to somebody who's not going to participate
I understand. Understand.
because ooh, the mind, the thinking I have to do to come up.
Yeah.
My head be pounded because I wanted to make it as realistic as possible. I didn't want to just throw out some arbitrary medications or some arbitrary values. I actually did research what is normal,
Mm,
um, what is the proper dosage if they were on this med. So I wanted to make sure that I was as realistic as possible because I'm dealing with people who might have, a medical background. So I
mm,
don't want to say they on metformin and that
mm,
milligrams is 2 milligrams a day when metformin is not in 2 milligrams. So, although
mm,
of course I was familiar with the diabetes medicine, I did that for nearly 10 years, but as far as
mm.
a lot of the other medicine, I had to look up.
You did great.
I
You did
appreciate it.
great. Okay, is it a medicine?
It is a medicine.
Okay, because some of these names, I know it's not the statin or the hydrochlorothiazide. So it's one of the 3 on top.
Think about that. I'm gonna see. I'm gonna go back to the inclusion criteria. Think about see which side is on. See, I just highlighted what was wrong. Okay, go to inclusion 5
Okay.
and 6.
Okay. You see, the problem is I'm not sure of the indications that the medications are used for.
Okay, so as a CRA, guess what we have to do? We have to
Yep.
Google.
Mm-hmm. We
Yep.
do the same on site.
Yeah, so we have to Google because a lot of, some of us were not study coordinators before we became CRAs, and the protocol does not provide a list. So we have
Mhm.
to Google it. So I'm gonna help you out. So they have to be on an ACE or an ARB. Neither
Okay.
one of these medications is an ACE or blood pressure. So the Divant is a blood pressure medication. It's not an ACE or an ARB. And the Verapamil is not an ACE or an ARB. And they can only be on two high blood pressure medicines. And the hydrocolizide, it also is a diuretic, but it acts as
Yeah.
treating blood pressure. So they're on too many blood pressures.
Mm-hmm.
So
Good
yeah.
catch.
So that was subject 3. Now, did you look at 5?
No, I didn't get a chance to.
Okay, so I'm just gonna go over all of 5.
Okay.
Okay. Okay, so first, what I did was I subtracted uh 212 from 1952. So this person is 60, so they qualify from that standpoint. Then I
Mm-hmm.
went to the medical history. It says she has Crohn's, hyperlipidemia, hypertension, LADA, rheumatoid arthritis, stable angina, and she has non-small cell lung cancer. So that's what that stands for. So if you see the site just abbreviated, it's our
Mm-hmm.
responsibility to Google that to see what that is. I purposely did not write it out
Mm-hmm.
because, as again, CRAs is our job to investigate. So that's what that stands for. Not although it wasn't in my exclusion criteria about having cancer, a lot of times cancer within the last 5 years is an exclusionary situation. But what makes hers different? Okay, so first we're gonna go up. It says the Asian female with she hasn't had a period since October of 2011. CRA collects the FHA to confirm menopause. Okay, so based on the inclusion exclusion criteria, and I'm not going to flip back, I'm just going to say what it says. A woman has to have had a no period for 12 months. So if she was screened in August and this is October, that's only 10 months. So that's why that's not a good one. So it doesn't matter what this her FSH lab is going to come back and say. She has to have not having a cycle for 12 months. Then we go into her patient had an ER visit on the 28th of July of 2012 for a Crohn's flare. Okay, so she was not admitted. It says the ER visit. So that actually wasn't one. I thought I had a time period, but I don't. I just got on the 28th. So she left, so that wasn't one. But I got Crohn's disease. So Crohn's is what kind of disorder?
Immunosuppressant disorder.
Exactly. So right off the bat, this is a red flag. That 9 times out of 10, this person wasn't going to qualify. But she might have Crohn's and don't currently take medicine, so it's worth investigating further. Latent autoimmune disease in adult. I'm sorry, diabetes in adults, bladder. That's also autoimmune. So it presents as a type. So a lot of times, and I didn't learn about this type of diabetes until I got into research, but a lot of times patients are misdiagnosed with type 2 because they are heavier and they get it as adults. So doctors just assume that it's type 2. Then further testing a C-peptide, um, forgot the other test they do, but they do a C-peptide, a glucose tolerance test, I believe, and it was another lab to determine if they got LADA. And so it's like And so it's autoimmune is going to eventually prevent the pancreas from making insulin. So they're going to be treated eventually with just essentially just insulin. And then she has rheumatoid arthritis. That is another autoimmune disorder. So she got three things um, that is attacking her immune system. Again, she may or may not take a immunosuppressant drug. So let's go over here and see. So she's on at least ACE or an ARB. She's on this drug right here. So um that is good. But then she's on two autoimmune suppressant medications. She takes this Katrina for her lung cancer, and she takes this medicine for her Crohn's. And as we can see based on her labs, they are affecting her what? You know what the AST?
CNALT, yeah, liver function.
Yeah, they're affecting her liver functions, and even her kidney functions may be attributed. And she also has a low EF. So it is essential, although she does not qualify. And I think that this person follows up with her primary care or her rheumatologist. She needs to figure out, or her oncologist. She needs to have them to reassess her labs and see if these two drugs are contributing to why her liver enzyme, because they both are known for affecting the liver and the kidneys. This class of drug, and so she needs to report this. Um, I don't think ethically the investigator can call either one of these people and provide this information because it's related to a study. Maybe he can with of course the patient's permission, they sign medical release. They can verbally discuss, but I don't think that they're allowed to send those study labs to that individual. But she definitely needs to follow up. And then her other exclusion. She did not have a diagnosis of atherosclerosis. So even though she's had hypertension, hyperlipidemia, which is high cholesterol, high blood pressure, she did not have that diagnosis. So each group had a person that just had a whole lot on. Then I tried to do a person that didn't have much, and then an in between. So um, you're welcome to look at those other three at your time, and just to see if you could catch what the issues were, and and just learn from it.
Thank you so much.
Okay, so we only got one more slide, which I think is just you telling me what you learned. Let's see, because like I said, these were just the scenario slides. Just let you look at my nice little picture stuff. That was three. I'll move him down. That was 4, 5, and 6. Okay, so if you want to discuss one or all of those questions, you're welcome to.
Absolutely. Well, of course, it was a good refresher course for the inclusion exclusion. It's really important to read between the lines, and just because the PI said the subject qualified does not really mean that, and it could be just an PI oversight. So as a CRA, you really have to do your research, review, or verify. I do have a good understanding of the inclusion exclusion and how to proceed with patients based on case by case. Apply to at least one of patients based on their health and lab results. And of course, I think one of the scenarios, a patient had dialysis already, even though it was not, in the inclusion criteria, but it's kind of like if you're in dialysis, then your renal functioning is really affected. Exactly. So I think that would be also an exclusion, even though it's not per sponsor.
So that's when that PI has to make the discretion. But typically, if you're on dialysis, your EGRF is going to be real low. I think they start dialysis when it hits 15, if I'm not mistaken. But don't quote me, medical doctors that read this. And then of course, a person can be on the acute kidney injury and had a permacath and be on dialysis just for a few days. But whatever the case may be, I would definitely probably consider that as an exclusion. Well, I just want to thank you because, like I said, I was hoping that everybody who hit the poll was going to show up. Do you have any questions for me?
Yes, I wanted to know if you have any more training courses coming up.